My name is Dr. Irwin Goldstein, Director, Sexual Medicine at Alvarado Hospital in fantastic and beautiful San Diego, California. This is the 11th video in a series of educational opportunities to learn about penile revascularization surgery for young men with artery-blocked erectile dysfunction. Previous videos have identified that the artery to the penis can become blocked in a young man that causes alteration to the penile erectile mechanism under various circumstances, such as bicycle riding on a narrow saddle with a long protruding nose extension, such as following a penile fracture, especially with the partner in the superior position, and such as following falls, kicks, or blunt trauma to the perineum. This video 11 will focus on blockages to the artery to the penis causing erectile dysfunction after the young man suffers a pelvic fracture. Slide 1 depicts the focus of video 11, artery blockage erectile dysfunction and its association to pelvic fracture accidents. Slide 2 defines pelvic fracture as a disruption of the bony structure of the pelvis, usually from high-energy forces such as motor vehicle accidents. It is estimated that there are over 60,000 patients with pelvic fractures every year in the United States. It is estimated that 50% of male patients who sustain a pelvic fracture suffer erectile dysfunction. Slide 3 depicts the ischiopubic ramus of the bony pelvis as a connector bone that connects the sit bone, the ischiotuberosity, to the pubic bone. The integrity of the ischiopubic ramus bone is commonly disrupted during a pelvic fracture. The internal pudendal artery to the erection chamber of the penis lies just next to the ischiopubic ramus. Slide 4 further reinforces the close approximation of the internal pudendal artery to the ischiopubic ramus. Fracture of the ischiopubic ramus can dramatically alter the ability of the erection artery to do its job, that is, to provide high perfusion pressures to the erectile mechanism during sexual stimulation. A blocked artery leads to a poorly spontaneous, poorly rigid, and poorly maintained penile erection. The following is an animation re-emphasizing the relationship of the internal pudendal artery to the ischiopubic ramus. As one can see, the very critical artery that provides high-pressure perfusion blood to the erection chamber passes just next to this connector bone. In a pelvic fracture that disrupts the ischiopubic ramus, this distal portion of the internal pudendal artery can become disrupted and blocked. As discussed, a blockage in this critical artery to the erection mechanism will lead to pelvic fracture-associated artery blockage erectile dysfunction. The next slide reviews a peer-reviewed publication examining the arteriograms of men who suffered a pelvic fracture. As can be seen, the distal portion of the internal pudendal artery, as depicted by the red arrows, is disrupted just as the artery passes in association to the ischiopubic ramus. The final slide reveals the arteriogram of the patient John, who graciously agreed to be interviewed and to discuss his story of undergoing a pelvic fracture and then undergoing penile revascularization surgery to treat his pelvic fracture artery blockage associated erectile dysfunction. John's arteriogram is on the left, showing the disruption in the artery as it passes next to the ischiopubic ramus. A normal arteriogram is on the right.
I used to commute to work on my bike each day, and one day, it was May 28, 2009, I was riding to work and I was at a stoplight, and 2 lanes over from me was a dump truck with a trailer, and the light was red. We were kind of stopped at the intersection, and the light turned green. I proceeded to go straight through the intersection. The dump truck turned right across my path, cut me off, and continued going right, and unfortunately didn't see me, and I got dragged underneath and run over by the rear wheels of the dump truck over my midsection and my legs.
How,
And then
what
the
do you
front
think
wheels of
that,
the
what,
trailer of the dump truck went over me as well, and then the rear wheels of the trailer kind of pinned me by my shoulder, and then the dump truck came to a stop. So lots of injuries resulting from that.
John, what do you think the dump truck weighed?
I have no idea. It was full. It was coming from a construction site. It was full of material, so I think they weighed quite a bit.
Like several tons, right? Probably several tons of weight?
Probably 25 tons or something like that.
Oh my gosh. Okay. So what injuries did you suffer?
Quite a few. Quite a few skeletal injuries. My pelvis was broken in 5 places. 3 vertebrae were crushed. My hip was broken. Ribs were broken. Sacrum was shattered. The sit bone was broken. And then all kinds of soft tissue injuries. I was kind of bleeding internally very badly. I almost bled to death at the site. Pretty much immediately, as soon as I came off the medication, I was in the hospital for I think it was 11 days or 12 days or something like that. As soon as I came off the medication, I realized that I wasn't getting morning erections or any of that kind of stuff. So there'd be nothing up to that point. I was 39 at the time. That was unusual at all. So it was a pretty stark contrast. Noticed immediately.
And you were married at the time, right?
Yeah, married and had 2 kids.
And how did you approach physicians in trying to get better sexually?
Well, I had because of the accident, I had right off the bat. I had urologists among a number of different specialists, neurologists, urologists, orthopods, all kinds of specialists that were working with me just because there's a lot of different types of injuries. So right off the bat, I had urologists doing tests and I had trouble with urination, all kinds of things. So this was something that was identified early on, and I never really had to seek help. I was already in the treatment stream with a urologist.
John, how'd you get to San Diego?
The urologist I was working with in Vancouver, Ryan Patterson, felt that the revascularization surgery, he had heard about it, and he thought that might be the best course of treatment. So he knew of 1 or 2 physicians in the U.S. that did that type of surgery. So he had given me some contact information, and I had spent a couple of months of phone calls trying to track somebody down. And there was apparently some of the Mayo Clinic, and that didn't turn up anything. The person who was doing it was no longer in the country. There was another person in Boston, which ultimately turned out to be you, but contact information I had was in Boston. So it took me quite a while to get to the San Diego clinic.
And the testing you had in San Diego, how would you describe it? As unusual, or?
No, it was actually exactly the same as what I had in Vancouver in preparation. So we pretty much did the testing I had over again. So
Okay.
It was, I'm sure it's unusual if you've never had it before, but for me, I'd had it probably 5 or 6 months prior, so it wasn't that big a deal.
And the surgery you had, what was the date of that? Do you recall?
Sorry, can you repeat that?
The surgery, the revascularization surgery, roughly when was that done?
When was it? It was April of
2010?
2010, I think. 2011, maybe. Yeah, it was a year and a half, a year and a half ago.
Okay.
2011.
And describe the recovery from the surgery.
I've had worse and I've had better. It wasn't, the first 2 weeks aren't all that much fun. Pretty uncomfortable in the abdomen area, but not terrible. I mean, I think it's the best approach is just to follow the instructions to a T. Don't lift anything heavy. Don't do anything you're not instructed to, because the last thing you'll want to do if you have this surgery is go back for a hernia surgery, because that area is still pretty tender. So it's not all that bad. I think the real turning point for me was there's probably 1 at 2 weeks where I felt a lot better, and then another one at 6 weeks where I could start exercising again. Those were 2 major recovery milestones. And but I mean, all that being said, I was working 7 days later. I was off medication and driving and going to the office and working 7 days after the surgery. So it's not terribly traumatic.
Awesome. If you were to relate the hardness of your erection before the bad accident, as we'll call it 10 out of 10, what was the hardness of your erection after the pelvic fracture prior to the surgery, and what do you think your hardness is after the revascularization surgery?
So pre-surgery, 0 to 1, and post-surgery, 7.5 to 8.
Excellent. Okay. So do you require like Viagra's and stuff to have sexual activity, or do you use them at all, or?
No, I don't bother. I mean, I took them for, I guess, a good year after the surgery because I think you just recommended that to maintain blood flow, but I don't bother anymore.
Okay.
I just stopped it after a year, 14 months or so.
So
if I should or not, I can keep going if you'd like me to, but...
no, it's it's whatever you want or need. That's the bottom line.
Yeah, so I don't require them for an erection. No.
So what if you had to live the rest of your life as a 0 to 1?
Yeah, it'll be a lot less fun, I suppose.
So what would you conclude about the revascularization surgery?
I wouldn't live like that. I'd just try and seek whatever remedy is available. Luckily, you've got several at your clinic, and this was definitely the preferred one for me. I think injections and things would work well for some people, and not that I mind injections. I've had thousands of them, but this was just the preferred method for me. If I was candidated for this is what I wanted. So,
would you recommend
whatever is necessary.
would you recommend a revascularization procedure if someone had a pelvic fracture?
Yeah, if you determined they were a candidate for the surgery, then without hesitation, I would.
Awesome. One last question. I don't know what you're doing about biking. Do you still bike ride or not really?
I would bike ride a lot more if I was able to sit on the saddle. So it's not related to the surgery, but unfortunately, my riding is 10% of what it used to be, and that's because of the calcium deposits I have on my sit bone and my sacrum. Again, I said it improves slowly over time. Maybe I'll get back to it, but at this point, I don't.
Well, I really appreciate it, John. Thank you so much for doing this. You have a great rest of your life, and in specific, a great rest of the day. And by the way, thank you for speaking to all the patients that I send you. Again, that's not easy to do, but I really do appreciate it. So thank you so much.
Oh, it's my pleasure. I have one thing to thank you for. I'll just remind you that 6 weeks after the surgery, we conceived our third
That's right.
child.
That's right.
So he's 8 months now. And he's doing
Well,
well.
that's awesome. Well, it's a pleasure to
Didn't
talk
happen
to you.
otherwise, so thanks for that.
All right. In summary, video 11 focuses on artery blockage erectile dysfunction that occurs following a pelvic fracture, especially a pelvic fracture that disrupts the integrity of the ischiopubic ramus. The artery to the erectile mechanism passes in close approximation to the ischiopubic ramus. I hope that the short segment examples of eyewitness footage of risky maneuvers are not too graphic and not too disturbing. They are simply meant to be educational and emphasize that non-bicycle riding injuries to the pelvis and perineum may result in a pelvic fracture and subsequent erectile dysfunction. Thank you once again to John, who bravely discussed his private story in public. Thank you, John. Thank you for listening.